Hi, this is Brian Kim. I'm going to share with you case number 193 in the best way to do cataract surgery series. This is a 1 to 2 plus dense lens, small pupil, and you're going to see my standard technique, double chop, cross chop, mechanical fracturing techniques. And again, the concept of hooking the lens up from the periphery and pulling the lens pieces up out of the bag. When you have a small pupil, you don't want to go after the lens pieces with high vacuum. Why? Because the pupil is right there. And so when you grab for the pieces, you might grab the pupil. Don't grab with vacuum, hook the lens up with the chopper. So here is the case. You can see I'm using the cotton tip to steady the eye and using a corneal marker, which will help me to center and size the rhexis. This is my paracentesis incision, first on the right side and then the left side, making sure I'm flat to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. As you can see, I use a cotton tip to control the eye. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule, and also in this case, some viscodilation. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then using the cannula to control the eye, I wiggle it towards me a little bit, and then I enter. And I've been doing this more. I like to do a two-handed technique now. I use a cannula to control the eye for the rhexis. So I puncture the center. These sharp tip forceps are excellent for puncturing. And then with the teeth closed, I just push towards me like it's a cystotome, grab the right side of the tear going around circumferentially. Now remember, this is the viscoelastic cannula. And so the nice thing about this is if I feel like the chamber is starting to collapse, I can push more viscoelastic simultaneously. One less instrument to put in the eye, might as well use the viscoelastic cannula since it's already in the eye anyway. Finish off the rhexis and burp some viscoelastic out, and this is the Capsulorhexis hydrodissection technique. I'll place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, decompress on the left side, sweeping and pushing BSS on the left side along the rhexis edge, and then pointing the tip down and rotating it from the right side, and the lens begins to spin. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, leading with the tip, getting under the rhexis edge contra-incisionally, pointing the tip down, turning the phaco-tip vertically sub-incisionally, fracturing the lens completely in half, that's double chop, placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco-tip, fracturing the right heminucleus against the phaco-tip, that is the cross chop. The chopper is acting like a chopping block. Lifting that first quadrant up out of the bag, fracturing it between the instruments, and then emulsifying the lens piece. Twirling that second quadrant in front of me, getting around it with the chopper, crushing it between the instruments, and then emulsifying the lens piece. Turning the second heminucleus in front of me with the chopper, again leading with the tip, getting underneath the rhexis edge, hooking the peripheral lens, going vertical, deep position of the phaco-tip, and that allows a complete chop, fracturing that piece in half, getting around that third quadrant, hooking the peripheral lens, crushing the lens between the instruments. Again, the phaco-tip is positioned deep to get a complete fracture. Using some vacuum to grab that lens piece up. Because I know where I am in three-dimensional space, you can use a vacuum when you know that you're not near the pupil, but when you're having trouble getting pieces out, just hook the peripheral lens. That's the easiest way rather than trying to impale the lens with ultrasonic energy and vacuum. Sometimes if you do that too vigorously, you might end up hitting the posterior capsule, hitting the iris, And so in my mind, in these situations, it's far better to grab the lens from the periphery with the chopper, pulling it up out of the bag, bring it into the central safe zone, and then fracturing the lens with the instruments. Now all the epinucleus has been removed as well. So I take the chopper out, push BSS in, take the phaco tip out. You can see there's a little bit of a Bell's reflex there. And I go in with the I&A handpiece. I start sub-incisionally, peeling from anterior to posterior. You can see the cortical material is rather loose anyways. Switching to polish mode, polishing under the rhexis edge. Again, this is a small pupil, not a tiny pupil, but it is a small pupil. I'll lift the iris to make sure there's no pupillary block. Polishing the posterior capsule as well. And the reason why you have to lift the iris, because when you're trying to polish the posterior capsule, I don't know if you noticed that, when you try to polish the posterior capsule, it'll be very deep. And so even though you don't have that classic reverse pupillary block, there is reverse pupillary block in these situations. So what happens is the posterior capsule is really deep and you're trying to polish the posterior capsule, but you can't because it's so far back and you can't get that purchase to grab the posterior capsule to polish. And so you lift the iris, and what that does is when you lift the iris, it releases a reverse pupillary block and the posterior capsule comes up towards you and you can actually access it much easier for polishing. So I don't know if you noticed that. You can go back and look at that again in this case. Go ahead and pulse BSS into the subincisional capsulorhexis, and I only do that because I know that the rhexis edge is right there. I was able to turn the eye and see it. Otherwise, if I can't visualize the rhexis edge, I don't do the pulsing. Push some cohesive viscoelastic to fill the bag, deactivate the irrigation, and then I'm polishing with the sweep, first on the left side and then the right side. I try to push the cohesive viscoelastic so that I can see better along the rhexis edge, but also to tent up the iris away from the capsule. When you're polishing, you don't want the iris right on the capsule. It might cause pigment liberation as you do that maneuver. You can see I'm using the sweep to retract the pupil contra-incisionally. I did it just for that moment so I can see the rhexis edge contra-incisionally, turn the eye away from me, and I'm able to place the lens into the bag. Go in with irrigation off, activate irrigation, turning the eye away from me, making sure that the lens is in the bag, disengaging the haptics off the optic, tilting the lens, rotating it 90 degrees clockwise, making sure the trailing haptic is in the bag, and then using the Maltzman as a final double check, making sure that both haptics are in the bag with the Maltzman. In the meanwhile, I'm also removing viscoelastic within the bag. By tilting it like this, you're removing the viscoelastic within the bag, you're giving it free access so the lens won't try to pop out of the bag because you're creating an opening. And so this is a very controlled way and a surefire way to make sure all the viscoelastic out of the bag and making sure that the haptics are definitely within the bag. Polishing under the rhexis edge, and then switching to visco mode, removing all the viscoelastic within the anterior chamber, keeping the Maltzman there in case I need it to protect the pupil as I'm using this very high vacuum in the final steps here. Go ahead and push BSS as I come out with the handpiece, but making sure I turn off the water first so that the iris doesn't want to come out, and then I'll hydrate my incision. So again, this is a pretty standard double chop, cross chop mechanical fracturing techniques on a fairly small pupil, 1 to 2+ dense lens. And you saw the concept of hooking the peripheral lens with the chopper, crushing the lens between the instruments, hooking and crushing the lens, especially with cross chop, against the phaco tip, and the phaco tip acts like a chopping block. This gives you exquisite control. I'm able to hook the peripheral lens up out of the bag and not using vacuum, because if you use vacuum, you might grab the iris, you might hit the posterior capsule. If you try to impale the lens using ultrasonic energy and vacuum, that's even more dangerous. All you have to do is take the chopper and hook the peripheral lens up out of the bag. It's really not that hard, but you just have to understand where you are and have good bimanual dexterity. Go ahead and hook that lens up out of the bag, get underneath the rhexis edge, turn the chopper vertically, and pop that lens piece up, crush the lens in the central safe zone, then you'll have exquisite control. You'll never have to worry about grabbing the iris, the posterior capsule, in a small pupil situation. This patient did quite well and had a nice clear cornea post-op day 1. And despite her fidgety eye movements, a little bit of a Bell's reflex, this patient had an excellent result, again, performing double chop, cross chop, mechanical fracturing concepts, hooking the lens pieces up out of the bag, and avoiding grabbing lens pieces with ultrasonic energy or vacuum. So I hope this was helpful to you, and I thank you for your attention.